All right, let's continue on. We're going to talk about invasive hemodynamic monitoring and specific arterial lines. So, a couple of different ways we can do invasive hemodynamic monitoring arterial lines. We can just set up a pressure system to a central line and get central venous pressure, or we can have what's called pulmonary artery catheters or Swan-Ganz catheters that are threaded over through the right side of the heart into the pulmonary artery. We see those mainly with our post-op hearts. So think about what patient problems or concepts would require that we would want to get hemodynamic monitoring. These patients are usually critically ill, and we need the most specific and the most accurate data we can give. I put a couple of just little JPEGs in here for you so that you can see. This is a cardiac monitor, so we've got heart rate and EKG here. I've got O2 sat. This red is an arterial pressure, and then this blue is CVP, and that's pretty standard. This is called a flow track. This is getting our hemodynamic values from an arterial line, and then we bring over the CVP, because remember CV, the V is venous, so this is coming from my central line. The rest of this is being calculated off an arterial line. And you can see I've got CO, CI here. Here's my SVR. Okay, so let's talk about the equipment that we need, because your healthcare provider is going to come in and say, "Hey, we're going to drop these lines, so can you get ready?" The first thing you need to do is get your line ready, primed, ready, zeroed, ready to go, because if they are critically ill, we need to hook that up and have an accurate value as soon as we hook it into the patient. We don't need to take time to zero. So I want you to understand why we zero. That's the next slide. It's not so much how you zero. There is a video that I've got for you that you can look at the process of priming your tubing and things like that. That's what's important there. It's not exactly how to zero. So what do we need? We need the invasive catheter. We certainly need a consent for this. That's up to the healthcare provider. I need what's called non-compliant tubing. Everybody around calls it pressure tubing, but the real name is non-compliant. The test name is non-compliant tubing. On that non-compliant tubing, it does have stopcocks and a transducer. The transducer is this little piece here that takes what's going on in the patient and changes it over to a waveform that I can see on the monitor. I need the flush system, so I need a pressure bag, which is this. This pressure bag is pumped up to 250 to 300 millimeters of mercury. Got a little gauge here. You've got up-close pictures in your outline, so refer to those. And then I need some fluids, so we're going to use 500 mils of normal saline, or we might use heparinized saline. That's just 1,000 units in 500. So the back of this bag is mesh so that you can see through it. It's important to know what we have going, and it's important to think about, do I want to use heparin? Would that be contraindicated? And if I have, this isn't a lot of heparin, but it is enough that could cause a problem, especially if somebody has thrombocytopenia, or this is enough heparin to put them in heparin-induced thrombocytopenia. Now, this is not an infusion like on a pump. The fluid does drip into the patient. When I clear my line, I'm giving them the fluid, so I will lose fluid in it, but it's not a drip. All right, so let's look at kind of close-ups here. So here's our transducers. This is a patient that has multiple things going on. Red is arterial line, but you need to trace this back, because just because it's red doesn't mean that whoever set it up did it incorrectly. Blue is usually CVP, and yellow is a PA pressure, pulmonary artery pressure, from that Swan-Ganz. You may just see these as clear. One facility uses the colors. The other facility, they're just all clear, so you got to trace the line back. Here's your pressure bag. This is the pressure bag. I will put the saline in here, or the heparinized saline, and here's the indicator light that says we're at 250 to 300. So there's actually a little mark that says 250. If you get beyond 300, it actually turns red and says you don't need it that high. The reason we put it under pressure is if I take this non-compliant tubing, which means it's very, very hard, it's not soft like pump tubing, and hook it into your artery is under pressure, and blood's going to come out through the tubing. So we put the system under pressure so that blood does not come out. All right, so let's talk about zeroing the system and why we zero. The reason we zero is I need an accurate pressure of the patient. I don't need to pick up the atmospheric pressure that we all live in. So there's a specific place, this is important, you need to know this, on the patient called the phlebistatic axis. And it's the fourth intercostal space, mid-axillary. It's right there. And that is the position that we are going to zero to. So my transducer needs to be in line with that. So sometimes you see carpenter levels. At one point in time, we had some big old tubing filled with some blue liquid running around. I use my pressure tubing that I have there, and I just stretch it across and make sure that it's equal. Because if my transducer is not at the phlebistatic axis, I don't have accurate numbers, and I don't need to be treating numbers on a monitor that do not reflect my patient, which is also why it's important to correlate those numbers with your patient. So this is the phlebistatic axis is approximate equal to the right atrium. The reason we zero is we open the whole system up, we push the zero button on the monitor, and we are zeroing out this atmospheric pressure of 650, 660, 670 that we live in. So when I hook it up, the only pressure I get is the patient. This is important to do before they put the line in. I can have my system set up and zeroed before they ever come to drop the line. That's important so I get an accurate value. All right, let's talk about what an arterial line is. So the purpose is a more accurate blood pressure. We use it for frequent lab draws. This is somebody that needs lab draws like every hour. Specifically ABGs, but if you just need a potassium, you can do a potassium. And for hemodynamic instability. So that's what an arterial line is. If we hook up that flow track, that extra special piece, we'll get hemodynamics. So what do we have to do before we put it in? Number one, an Allen's test should be put in. The information for arterial lines is in your skills book, and I believe it's skill 12-19. So the Allen's test is to make sure that I have good ulnar flow going to my hand in case that I have a really small artery and put a great big arterial line in there, or something happens to the arterial line, I still need perfusion to their hand. So the Allen's test should be done beforehand. I've not ever done it as a nurse. The healthcare providers do it. I do think cath lab staff may do that before they do like a radial heart cath, but an Allen's test should be done. Get your equipment together. The wrist, after this is done, we are going to put a dressing on it. Look at this and tell me what's missing. What's missing is a biopatch. So we can have the biopatch itself, or we are now seeing clear occlusive dressings. I always call them Tegaderm. I know it's a brand name, but that's just what I've gotten used to, that actually have the chlorhexidine patch on them. We need that wrist in neutral position, and we actually may put it on an arm board, which will just slightly hyperextend it, and we get a better reading. I also need them not to be bending their arm. And we're going to set our alarms based on the patient. All of our alarms, our cardiac alarms, everything should be specific to the patient. So what are the complications? Thrombosis, embolism, blood loss, and infection. The system should stay closed. It's hard to see in this picture, but right up here is a stopcock, so that is where we're going to draw blood. And we really are using what's called the VAMP systems, which is a needleless system. So the vacutainer goes right on that. You stick your tube on it, and we're not having to use needles, syringes, and it's actually keeping a closed system. And the blood is pulled back through the catheter, and then we can give that blood back so we're not having problems with blood loss. Now, a thrombus or an embolism on the end of the catheter. If we think we have one of those, the last thing you would want to do is actually go flush your system. You flush the system. I'm actually going to go back one slide so that you can see. These little blue dots here, actually, they're called pigtails, and you pull them, and what it does is it flushes the system. It sends blood, it sends the fluid through the system. So your nurses may have you do that. But if I think there's a clot here, I don't want to flush the system. I would want to aspirate blood out. What do we do with removal? Make sure we have an order. Check to see if your patient's been on anticoagulation. If they have, you know you're going to have to hold pressure longer. The least amount of time you should think that you're going to hold pressure is for 10 minutes. Radial R lines are probably the most common. I have seen brachial, and on occasion we will have femoral. If you have a unstable post-heart cath patient, that sheath that they went through to do that heart cath, we can hook an arterial line up to it, and we've got an arterial line. Or maybe they're just so unstable they used the femoral artery because that's all they had, and their pressures were so bad that was the only pressure we could find. Those certainly need more pressure, at least 15 minutes. So you're going to hold pressure on this site. You're going to put a dressing on it. Think about the fact that you probably don't want to wrap a dressing all the way around it like 4 times after you've taken it out because you've put a tourniquet on. You need to assess circulation here. When you have an arterial line, you do need to assess distal perfusion. I don't have a pulse, can't assess distal pulse. Now, if I have a brachial A line, I can assess a distal pulse, which is radial. If I have a femoral, I'm going to do distal pulses, which is pedal, posterior, tib. If I have a radial, I'm assessing perfusion here. So, you've learned a bunch of P's about perfusion. There's 3 I like. I like color, temp, and cap refill. Plus, when I do cap refill, I'm doing temp at the same time, and I'm looking at it, so I can do all those all at the same time. So I expect to have all those, and you should look at all of those every 2 hours with somebody with an arterial line. Now, if you have somebody, this looks like a left arterial line, their right radial pulse is 3+, and their left with this arterial line is slightly less, 2++. Would you be terribly concerned? No, because they have a line in it. If it's slightly less, I'm not concerned. But if their right is 3+ and their left is 1+, I'm concerned. And is this pale, cool, and I've got a poor cap refill? If so, I've got a problem with the arterial line. One more note is I do see sometimes arterial lines are left in when they no longer work correctly. And the nurses are like, oh, we're going to use it for blood, and they might turn the alarm off. Well, think about this. What if something happens and this line comes apart? It comes apart somewhere up the system. Your patient could bleed out. So that's poor practice. If it doesn't work, we need to get an order and let's get it DC'd because they're at risk for infection. And if it's not working, we just need to get rid of it. Okay, so just a quick note on central line. We're going to talk more about this with how DCing them, risk for air embolisms with your TP and content. But with central lines, you can have a double, a triple, or a quad. This is actually a quad lumen. So we have, this is a white port, gray port, brown port, blue port. Up them, it does tell you what this is. This is medial 2, this is distal, this is medial 1, and this is proximal, and that is how we chart them and not colors. Your PICC line, which can be double or triple, don't say that, so those are done by color. On this quad lumen, FYI, this gray port is your bigger port. So if you needed to give blood products, we would actually use that. So here's 2 different IJs. We've already talked about why we like IJ. This is that tegaderm with that chlorhexidine in it. You can kind of see that little rectangular patch there. This has a bile patch. Those look like really great dressings. If my dressing's not intact, I need to remove that. These are sterile. If the dressing's not attached, we need to attach it. There are protocols for the hospital of how often we change the dressing. There might be dressing change teams, but if it's the middle of the night or the weekend, certainly in the unit, we're doing our own. So we need to do that aseptically. Get our, we have central line change kits, so get those out. Certainly, do our infection prevention, so wear gloves while we do this, and look at your CLAPSI bundle, and the specifics of your CLAPSI bundle are in your outline. Keep it closed, make sure we don't have air in there, and probably the most important thing that we can do is daily assess, do we need this catheter? Because if we don't need it, we need to get it out. And I know at one facility in town that is a nursing job to assess, do they need their Foley, do they need their central line, and if not, we need to get rid of them. Okay, that's what I've got. Be sure and check your notes. You've got some more details in that. Also, some specifics on zeroing and like if you've got somebody intubated, we're going to read that at end expiration. So be sure and check those out. Thank you.